These are our learning objectives in this lecture. Normal alimentary tract has 4 layers: mucosa, submucosa, muscle layers and serosa. In contrast, gallbladder wall has few layers missing. There is no submucosa, and there is single muscle layer. There is probably a reason for it. Submucosa layer is tough collagen-rich layer, so eliminating submucosa enables gallbladder to distend easily. Single muscle layer enables contraction just enough to push bile in bile duct in coordination with open ampulla of Vater leading bile into duodenum. Gallbladder is mainly divided into 4 parts: fundus, body, neck and cystic duct. Carcinoma gallbladder mostly occurs in fundus in 60% of cases, followed by body 30% and rest 10%. Due to close proximity of neck to CBD, there is early jaundice and neck cancer. Cancer in fundus have late jaundice. Gallbladder is covered by serosa layer which is continuous with liver. The hepatic side of gallbladder is deficient in serosa. Instead, there is thickened layer called cystic plate. In simple cholecystectomy, dissection is done between cystic plate and gallbladder as it is relatively avascular. However, this is why simple cholecystectomy is inadequate for cancer gallbladder as dissection is close to gallbladder. In gallbladder, due to fewer layers, tumor reaches serosal surface or liver at depth at which normally second muscle layer comes in other parts of alimentary tract. Lymphatic drainage from gallbladder first reaches cystic node followed by pericoldocal lymph nodes. Beyond pericoldocal, 2 routes are present for lymphatic flow. One towards retropancreatic nodes to aortocaval and another route follows arteries to common hepatic node to celiac node. Involvement of celiac node and interaortocaval node are considered signs of advanced disease. There are various modes of spread of gallbladder cancer: direct spread to adjacent organs, liver, CBD, colon, duodenum, omentum; bloodborne spread most commonly to liver; lymphatic metastasis; peritoneal shedding. One peculiar feature of this cancer is potential to spread along biopsy tract, hence inoperable disease. Pre-op biopsy is avoided. Looking at TNM staging, T1 is involvement of lamina propria. After lamina comes muscular layer T1b, then comes perimuscular connective tissue T2. It has been observed in studies that T2 disease on hepatic side has poor prognosis than disease on peritoneal side. The reason could be absence of serosa on liver side, early involvement of liver, direct drainage of cholecystic veins on hepatic side directly into liver. So T2 is tumor on peritoneal side and T2b is tumor on hepatic side without liver invasion. T3 is serosal involvement, liver extension, single extrahepatic organ involvement. T4 is multiple extrahepatic involvement, arterial and portal vein encasement. AJCC 8th edition differs from 7th edition in that in T stage, 2 categories are defined: T2A and T2B. In N stage, 7th edition was based on stations of nodes involved. In 8th edition, priority is given to number of nodes involved, with 4 being cut off between N1 and N2. At least 6 nodes must be examined for adequate staging. Clinical presentation is divided in 3 groups based on time of diagnosis. Diagnosed before surgery on imaging. Intra-op diagnosed for presumed benign gallstone disease. Diagnosed on post-op biopsy for cholecystectomy done for presumed benign disease. USG is most common test done on which cancer is suspected, followed by CT scan. There may be thickening of GB wall or mass in GB. Some patients undergo laparopen chole for cholecystitis with thickening of gallbladder wall attributed to inflammation. On intra-op, there may be mets or hard mass in GB. Few patients have no suspicion on pre-op USG or intra-op surgery, but post-op biopsy of gallbladder comes positive for malignancy. These are called incidentally detected gallbladder cancer. Patients may present with jaundice. Fundal and body mass are less likely to present with jaundice due to distance from CBD. Neck lesion present early with jaundice, or whole GB may be involved with CBD involvement. There can be CBD compression by lymph nodes, or rarely there can be associated CBD stones causing obstruction. Massive liver mets can cause jaundice when approximately 2/3 of parenchyma is replaced by tumor. In gallbladder, less than 3 mm thickness is considered normal. More than 3 mm thickness of gallbladder wall may be due to cholecystitis or malignancy. Features suggestive of gallbladder cancer on imaging are focal thickening of gallbladder wall, asymmetric thickening, polyp more 1 cm, when interface between liver and gallbladder is lost, means there is no clear-cut demarcation between GB wall and liver. Finally, mass replacing gallbladder is highly suggestive of cancer. Incidentally detected gallbladder cancer is when cholecystectomy is planned for gallbladder stones and there is no suspicion of malignancy on pre-op workup, but histopathology comes out to be malignancy. This group usually comprises of early-stage tumors, hence better prognosis. It occurs in less than 5% of all cases of gallbladder cases. Treatment is dependent on stage of tumor. For T1 or tumors limited to lamina propria, standard cholecystectomy is sufficient, as there is muscle layer in between. But when muscle layer is involved, T1B, simple cholecystectomy is inadequate as cancer cells may go beyond muscle layer on liver side. Plus multiple cholecystic veins drain directly into liver carrying tumor cells. Hence T1B onwards, extended cholecystectomy is done. Resection of liver portion deep to gallbladder is necessary with lymph node dissection. In extended cholecystectomy, unblock resection of gallbladder is done with portion of liver on gallbladder bed. 2 cm margin is taken from gallbladder and liver. If there is invasion of cancer in liver, then 2 cm margin beyond tumor is taken. In addition, lymph node dissection of hepatoduodenal ligament is done. There is variation in extent of node dissection in gallbladder cancer. Some also remove retropancreatic nodes also. However, celiac node and anteriortocaval nodes are considered metastatic. If present, surgery is abandoned. Liver resection in carcinoma gallbladder can be done in 2 ways. One is anatomic liver resection, in which segment 5 and 4B are removed as they form gallbladder bed and receive blood from gallbladder via cholecystic veins. In non-anatomic resection, instead of removing both segments entirely, only 2 cm wedge of liver is resected deep to gallbladder. Both anatomic and non-anatomic resection are equal. Adjuvant treatment in carcinoma gallbladder is to eliminate microscopic residual disease after surgery. It can be chemotherapy or chemoradiotherapy. Chemo is often given. Main drug is gemcitabine in combination with different drugs like cisplatin, oxaliplatin, capecitabine,